Yes, streaming start. Yes, streaming has already started. Okay, am I audible, visible? So I'm starting the class. Hello, hello to everyone. Okay. Good evening, good evening. So I hope you all had a great exam. Okay. And we'll be continuing with that. Okay. Audible, visible? Chal. T-shirt change? Yeah, good, good. Okay. Chalo. I thought you people might be missing me. So I thought I'll start session soon. So let's continue with the sessions. Okay. Okay, so I'll be discussing the questions and we'll be trying to add any corrections. You just help me in getting the corrections done. Okay. So let's start the discussion and we'll be doing the question. So first question, you see this one, and what is this graph? As you can all see, this is our what graph? The classical graph of what? Oxygen hemoglobin dissociation curve. Okay, so oxygen hemoglobin dissociation curve is there, and yes, what is the funda about that? Okay, so let's start. Okay. Okay, so first we'll discuss is about the curve. You know already the normal oxygen curve. What is the normal curve? So normal is sigmoidal. Normal is sigmoidal. Normal is sigmoidal curve. And what are the variations we have to remember? So remember, first is right shift and left shift. So you already know right shift and left shift. Left is called as Haldane effect and right is called as Bohr, and it causes decrease affinity and release oxygen, and the Haldane causes this. And this I told in each and every session that what, that ra 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 la la la, that is 100% sure exam in any exam, and this is your yes bind oxygen in lungs. So lungs will see the Haldane effect. Now first question, what is left shift example? So example is fetal hemoglobin. So fetal hemoglobin will cause a left shift. So this will be a left shift. So this graph is showing a left shift, but the shape is not sigmoidal. It is called as rectilinear hyperbola. So what the shape is? It is called as rectilinear hyperbola. This shape is, I'll just use a separate pen to write down. So this is called as rectilinear hyperbola. Okay. तो कितना बोला? बहुत बोला. Hyperbola, rectilinear hyperbola. Okay, and this rectilinear hyperbola curve looks like this. Okay, तो देख रहे हो कुछ ज्यादा ही बोल गया ये. Hyperbola, and it is seen in myoglobin. So myoglobin, so first it is left shifted and it's almost like a rectangle with a upward and flat. So what happens? Myoglobin, it has very high oxygen affinity, very high oxygen affinity, and store oxygen in muscles. And because it has very high, and bind what? One myoglobin bind one oxygen. So that's why it is not a sigmoidal curve. It is rectilinear hyperbola. So answer is clear. The question, the answer is, it is not your fetal hemoglobin. Fetal will be like this. It will be left shifted. but it will be similar to this graph. Okay, so it is not a, which graph? It is not a left shift, it's a rectilinear hyperbola. Clear? Chalo. So I'll discuss, don't worry. Okay, don't worry, you can just inform me, I will solve this question. Okay, chalo. Okay, next question. Myoglobin carboxy again cause left shift and decrease saturation. So two changes occur because it occupies this. The graph will be left shifted and this. So this will be CO curve. This will be CO curve. So what curve is this? CO curve. Okay. So this is our CO curve. Can you see this? So this is left shifted and also going down. Why? Because of less saturation. So this dotted line shows the carboxy hemoglobin curve. Carboxy hemoglobin. And this curve which you see extreme left shifted, and this is your myoglobin. This is fetal hemoglobin. Again, it's sigmoidal. They're all sigmoidal shapes. Okay. So which one is not sigmoidal? It is your myoglobin. So the answer obviously in this question is what? It is not methemoglobin. Again, methemoglobin shows a left shift. So best answer is myoglobin, which is almost rectilinear hyperbola. Are you clear? Chalo. Next question. So these are the curves I have got for you. This is methemoglobin. Again, it's a left shifted graph, and that is the case. Okay, clear? So it make it difficult. That's why it causes reduced oxygen release. It is a high affinity release, oxygen release. Okay. So what are left shifted? You can say it is low temperature, it is high low carbon dioxide, high oxygen. They all cause the left shift. Okay. It is covered in class and I've discussed that in notes also. You can see methemoglobin is again left shifted. Okay. Now least AV difference. So remember, AV difference depend on the organ oxygen use. Organ oxygen use. If a organ use lots of oxygen, there would be very high. So I don't. So that is why maximum. It's reverse. So that's why heart has maximum oxygen per 100 grams. So heart has highest oxygen use per 100 gram. So that's why heart will have what? Maximum AV difference. In fact, normal AV difference, right? Normal arteriovenous oxygen difference is around 5 ml%. How do you get? Very simple. Artery has around 19 ml%. Artery PO2, yeah, artery O2 is 19 ml% minus venous O2 is 14. Give you a value of 5 ml%. Okay, 5 ml%. Okay. ठीक है, fine. Okay, now in heart it is around 10 ml%. Why? Because in the vein of which one? The coronary sinus vein, it can be as low as 9. So remember, heart has maximum, hence. Now which organ consume less oxygen? The answer, liver also consume, kidney less, and skin. So these two have low consumption. So kidney is having very high blood supply, but because we get so much blood, the difference become less. So that's why skin and this, they have low difference. Low difference. Okay, let me show you the table. So this is a table. You can say brain mass is 1.4 or 5 kg, blood supply is 750, oxygen consumption is 52 per ml is 52, 54, maximum blood flow is 1500. Is the brain in any mental activity. Oxygen is 46. So you can see highest is muscle, before that is liver. So liver has the highest oxygen consumption, highest blood is also liver. So what organ get highest blood and the oxygen? Answer is liver. But when you take per 100 gram, it is your kidney and the brain, heart. So heart get highest per 100, and here it is again kidney. So which organ has the highest oxygen per 100 gram? It is heart. Which organ has highest blood flow per 100 this? So blood flow is kidney, total is liver. So total is liver. Are you clear? Total is liver. Now AV difference, you can see skin has very low AV difference. Skin and kidney have very low. So what are the minimum? 1.4. Kidney has the lowest one. Kidney has the lowest one. Okay. So why? Because kidney gets so much blood that all its oxygen demands are met by this high blood flow. So that's why it doesn't has to extract lots of oxygen. Why? O2 consumption is 18. It just need 18 oxygen. And because of such a high blood flow, it will not be able to extract lots of oxygen. So that's why it will be minimum. So let me just revise and summarize for you. So first question, write down. So what is the concept? So maximum blood flow and oxygen supply is liver. Then minimum flow skeletal muscle. MCQ. So again exam question, minimum flow is skeletal muscle, minimum blood flow. They are very low, 2 to 3 ml per 100 gram per minute. It is the minimum. Then if they ask you which value, which organ is having what? Yes, maximum blood flow per 100 gram. The answer here is your which organ? Kidneys. Almost 400. And if they ask you maximum oxygen consumption per 100 gram, the answer is heart, not the brain. Okay. And minimum AV difference is kidneys, then skin. And maximum AV difference, it is your heart. Because heart get very less blood, 250 ml, so it extract highest oxygen from there. So you can see this. So that is the funda. Are you clear now? So this is the funda we will see. Are you clear? So you can see it very well here. Highest flows, highest difference. Okay. And O2 consumption of which organ is highest? It is your 51 liver, and then it is your heart in per 100 ml. Okay, per 100 gram, sorry. And AV difference it is a maximum. Okay, 11 is heart. Heart is the highest oxygen difference. Okay. Next, part of nephron and anti-diuretics. Something was there. I don't got the question, but let me explain. PCT, what is the anti? We have carbonic anhydrase inhibitors. Carbonic anhydrase, like acetazolamide. They block the, yes, carbonic anhydrase. So it block the sodium hydrogen exchange and also the sodium bicarb import. So that's why it is having highest funda here. Okay, so highest funda is PCT. Okay, so it's carbonic anhydrase inhibitor. DCT contain NCC, and who block the NCC? So it's inhibitor blocked by thiazides. Collecting duct, we have INAC, and INAC is blocked by our which ducts? Yes, amiloride. This I discussed in my kidney lecture also. If you can see, it's covered there details. And ascending loop has NKCC. Who blocked the NKCC? NKCC is blocked by our very famous loop diuretics. So I don't know what the question was. So I just gave you the answer. Ki part of nephron, and if they were matching, you could have matched it very well. And the image is there. You can see. So this is the notes, eGurukul notes. You can check. Osmotic PCT, carbonic anhydrase PCT, loop are ascending loop NKCC. They are class notes. You can see. Thiazide early DCT, potassium sparing, collecting duct, INAC. So I think everything is there in the notes. You can check it. Okay. Matching question, na? So you can match the question if you know the concept clearly. Okay. This is osmotic diuresis. Everything is covered there. Okay. Now match the following. It's a easy question. Kaffar are liver. Kaffar are in liver. So kaffar are in the liver. Parietal cell is stomach for acid secretion. We all know. Histiocyte are macrophages in the skin. We know. And Clara cell are in lung. They are doing secretion of mainly surfactant, also protect the bronchial, epithelium. So lungs, Clara cells are there. Okay. Yeah, torsemide is again loop diuretic. Torsemide is loop diuretics. Aceta is CA inhibitor. Okay. So what is the answer? So Kupffer cell will go with liver. So A go with 3. So A 3 is B and D, right? Stomach, parietal, 2, B is 1. So B is 1. So means B and C. These two are wrong. So now B and D are the only option. C, skin goes with histiocytes, goes with connective tissue, skin and connective tissue. So I'll go to skin and connective tissue. So 2. So it is 2. Can I write it? 2. Yes. So it will be 2. Okay. And D is 4. So answer will be D. Clear? Okay. See again, dust cells are basically present. They are also called as pulmonary alveolar macrophages. And what the function? They do the phagocytosis of the foreign particle entering the airway. Okay. So I think that will be the best answer in this case. Are you clear? But Clara cells are in the lung. That is the best answer. Okay. So answer would still be D. Okay. Amount of insensible water loss. So first is, what is insensible? Insensible is you don't even know. Like urine you know, and we know the amount that we are losing in feces. We know the water is there in feces, but it is mainly through lungs and skin. And the value is approximately 800. Total is around 800 to 900 per day. So the value 800 to 9. Okay. So remember, urine is approximately how much? Urine is 1.5 to 2 liters, but that is sensible. So let's just show the table. So intake, we drink 1 to 2 liter of fluids, then water in food is 1. So total 2 liter we are ingesting, plus water produced by metabolism is 300. Total gain is 2600 is total gain. Okay. Output is 1.5 liter is urine, 200 this, and insensible is lung and skin around 900. Okay. Don't worry, I'll solve the question. I've given both the options. See, I got two options. One was total value, one was per hour. So obviously it cannot be this 100. So answer will be per hour. So best answer was per hour. So I think this question itself is not right. It should be per hour. Per hour. So we'll go with per hour. And if per hour you can calculate a person whose body weight is 60 kg, or let's say 50-60 kg person. So for 50-60 kg we need to, in a day there are how many hours? 24 hours are there, na? So 24 are there. So we divide by 24. So let's do for calculation purpose. I take it as this. So roughly it gives 30 ml per day. Sorry, per hour. 30 ml per hour. Are you clear? So it is 30 ml, which is given in data also. See. So urinary loss is 60, fecal is 10, and insensible is 30 ml per kg per day. 30 ml per kg per day. Okay. Morning session was asked total loss. So total you can calculate, it is 2.6 liter. Total fluid loss is 2.6 liter, which include urine, stool also. Okay. Clear? So respiration, when you breathe, it is humid air which is coming. So you lose 300 ml from the lung, 600 from the skin in the form of various sweat, etc. Okay. So it can increase in exercise because of hyperventilation and increased sweating. So the answer I think will go with how much? 50 ml per hour is a better answer out of all of these. Okay. Clear? And total value, if they're asking, we'll go for 800, 900. So I don't know the options, but if I take per ml, I'll take 50 ml. If they're giving total value, I'll go with 800 or the highest value. Some say 500. So 500 ml per day will become the answer. Okay. Let's see next question. Is which are the nerves involved in oculocephalic reflex? What is the other name of this reflex? Doll eye reflex, also called as the doll eye. And what is the purpose of this reflex? It is used basically as a brainstem function. So in comatose patient, it's a brainstem function. So brainstem functions because all these nuclei are present in the brainstem. What are the funda? In a normal person, when you turn the eye, what happens? The eye follow the head movement. Okay. And this is your vestibulo-ocular reflex. In this case, when you turn the head, the eyes will go in the opposite direction, just like a doll. So you know the doll, when you lift the doll, eyes are open. When you lie the doll, the eyes will close. Same way. So I'll just show you a picture. So when you turn the head, the eye will move. So that is called as a oculocephalic reflex. Okay. Done. So eye deviate up on flexion and the eyelid will open. This is called as the, yes, an extension causes eyes to deviate downward. So this is called as the, yes, your doll eye reflex or oculocephalic reflex. Now what it needed? So obviously as there's a head movement, what sends the head movement? It is vestibular apparatus. And what is the nerve it carry? Eighth nerve. So eighth nerve. Then what is causing the eye movement? Here it is causing a lateral movement, that is abducens, and also it is the oculomotor. So we need which muscles? We need ocular muscle. So extraocular muscles. Which one? So it is sixth nerve, 6cn, which is abducens supply. And we have the third cranial nerve, which is oculomotor. So these are the nerve which are needed. We don't need the trochlear nerve, that is superior oblique is not needed here. So that's why this is the pathway. So as you move the head, the semicircular canal, which is part of vestibular apparatus, they sense the movement of the head. Then they inform it to vestibular nerve and the nucleus. Now via Scarpa ganglia it reaches vestibular nucleus and inform the head is moving. Once the head is moved, this information from the vestibular, both right and left, goes to the abducens nerve, which is the sixth nerve, and also the oculomotor, which is the third nerve. And from there they go to the, yes, the muscle, and they cause the movement of the eye. This is called as the oculocephalic reflex. If it is present, it indicates brainstem is functional. Are you clear? So the best answer, third, yes, sixth, yes, eighth, yes, seventh is not involved, and fourth is also not involved in this case. So answer will be A, C, and E. Okay. I'll send the PDF later in the group. You can check it. All of the following is a method to detect mucociliary clearance. Okay. So this is a topic which we teach, but in not terms of testing, but only in the terms of what the effect. So this is very important. Why? Because this ciliary clearance help the mucus go to the upper airway and then you cough it out. So it's the protective mechanism against the foreign particle, and it is damaged in smoker, and that is a very common part of your chronic bronchitis, cystic fibrosis. So it is poor in chronic bronchitis, COPD, that is COPD. Okay, also bronchiectasis. So all this condition, we have a defect in the mucociliary clearance. Okay. Now I have to search net for this because I know just one or two method. Otherwise, even I have to search the net. So for saccharine method is there. So they will put small saccharine particles at the inferior turbinate and ask the patient to feel. So if it's moving, they can taste the sugar. That is called a saccharine. Yes, nasociliary clearance. So I'll just say, so this is the mucociliary clearance test. How do you do? They will put a, yes, small particle saccharin 1 centimeter behind the interior end of inferior turbinate, and if there is a normal, this saccharin will be swept backward to the nasopharynx and the person will perceive a sweet sensation. This is called as the, yes, what test? Nasal mucociliary clearance. Okay. Then we can also use charcoal. Charcoal can also be used, and it is not a very, prominent one, but it can be used. But best is this one. Also we can use scintigraphy. So this scintigraphy is also used for the purpose of a nasal MCC. Okay. And electron microscopy will just give you a structural analysis, not the motion. So just for structure, it gives you structure. Like example, cartilaginous syndrome, when there is a damage to the cilia, we can check the structure of the cilia, but not the functionality. So for function, I think we'll go with this. So answer should be C. So we'll go with C because this is true, this is true, this is also true. They all are true. Electron microscope is only for structure. Anyhow, we have to freeze the structures and then we visualize. So that's why they are dead structure. You cannot check the functioning in this case. Are you clear? So we'll go with C. Okay. Water absorption from PCT. Okay. In HC. I don't know what this HC was in ADH. So in the absence, I think, in absence of ADH, it was absence. In absence of ADH. So first remember the rule I will tell you is PCT is always isotonic. Remember the rule. PCT is always, you can check the notes also, always isotonic. Why? It gets filtered plasma. So always isotonic. So what is PCT specialty? it is always isotonic. Okay, now what happens? Okay, descending loop, it absorbs the water, always hypertonic, always hypertonic. Okay, then ascending loop and DCT, always hypotonic. So these are your always in a healthy person. In disease, obviously anything can happen, but in a healthy person, always descending is hyper, ascending and DCT are hypo, around 100 milliosmol per liter. Now what happened next is interesting. This hypo urine enters CD. It enters CD and there are two possibilities. Either ADH is present or ADH is absent. If ADH is present, it will absorb the water, and as it absorbs the water, hypertonic urine will be formed. So you'll get hypertonic urine. And if ADH absent, like diabetes insipidus, you cannot absorb the water, so now it will be hypotonic. Okay, fine. So if they're asking osmolarity, it is isotonic. It is 285 to 295 milliosmol per liter. This is there in your notes also. You can check eGurukul notes. It will be present. So 285 to 295 is the osmolarity which is leaving our PCT isotonic. Okay, clear? Isotonic is the answer. Where is hypo? I am fine now. Dr. Crepitus, thank you very much. So are you clear? So even if ADH is high or low, it will still be isotonic. Okay, remember? Now you will say, but sir, I heard if ADH is absent, person will have diabetes insipidus, and in diabetes insipidus, the plasma osmolarity increase. I agree, but remember, it will still be the same urine which is going out. So even if the plasma osmolarity become increase, the urine will still be same as plasma, so it will still remain isotonic. Are you getting my point? That means it will remain the case. Okay, mannitol act on almost all the area, mainly PCT, which is absorbing the highest amount of sodium. So that's why again they will act mainly in the PCT. You can see this. So it act mainly in the PCT because where is highest sodium absorbed? PCT. So where will osmotic act maximally? They will, yes, cause the water loss mainly from the PCT area. Okay, clear? So done now. So I will give the answer. It will remain isotonic. If someone say no sir, it should be hyper, because we read in ADH, this insipidus, there is hypertonic plasma. I agree, the plasma is hyper. Okay, but urine will be same as plasma. Iso means same as plasma. It doesn't mean more or less. Okay, so that will be the answer. Okay, next, how does 2,3-BPG decrease the affinity of hemoglobin to the oxygen? So I don't got the options, so I've just received these options, so I will explain these options to you people. So what are the options? So let's start now. First is, what is the story in the options and what are we going to see or discuss here? So let's start. First, BPG actually bind to histidine and the lysine of the beta chains. What the BPG do? So 2,3-BPG bind beta chain of hemoglobin A and displace oxygen. That is, reduces the oxygen. So that increases oxygen release. So that is how you get oxygen release is increase. Whereas fetal hemoglobin HbF doesn't bind to 2,3-BPG as it has no beta chains, and that is why fetal hemoglobin will love oxygen more. So fetal hemoglobin has higher oxygen affinity than HbA. So once again, fetal hemoglobin has higher oxygen affinity then what? Then HbA. So clear now? Then the HbA, and that is why fetal hemoglobin can extract oxygen from maternal hemoglobin. So that is why what it can do. So that is why HbF extract oxygen from maternal HbA. Are you clear? From the maternal HbA. So what the answer here? The answer I'll show this also. See, so BPG bind with deoxyhemoglobin beta chain and decrease the affinity for oxygen and allosterically promote the release. That means it doesn't bind the oxygen binding site, but because it's binding to other site, mainly where it bind to the lysine and histidine. This is an exam question on AIMS 2000 and I think 14-15 when the NEET came. That time they asked where does it bind, mainly where the lysine and histidine residues lie. So that's why it will bind and cause the increased oxygen release. Are you clear now? So that's why it causes the allosteric effector which cause the oxygen release in this case. So clear now? So that is causing the oxygen release. Done now? So the best answer, it is the beta chain of the hemoglobin. Okay. Fine. Okay. Now graph with FeV1, FVC. So so I will teach you all the graph, okay, and do it so that you don't make a mistake in this graph. So I'm teaching it separately. So it is already taught in the eGurukul video. You can watch it. So let me explain. First question. This is your graphs. So first, this is the vital capacity. This is VC, vital capacity. And this is the time. This is our time. Okay? 0, 1, 2, 3. 0, 1, 2, 3. सही है? So clear now? So 0, 1, 2 and 3. Now first question, how much come in first second? Let's say if this is 5 liter, let's say 5 liter. In first second, how much air come? This is called as the, I'll just make it a bit sharper. So in first second, the air come is called as FeV1. Let's say 4 liter. So the percentage, so normal percentage is FeV1 percentage equal to FeV1 by TVC into 100, and that is normally 80%. So in a healthy person, 80% air comes out in the first second. In the first second, 80% air come, 4 liter. Okay. Now what happens in RLD? In RLD, there is restrictive lung disease like fibrosis, ARDS, silicosis, asbestosis. So all the RLDs, what happens? There is reduced volumes, reduction in all volume. Clear? So reduction in all the concept. Fine. So reduction in all the volumes will take place. Okay. So let's see what the graph. So same graph will be there, same graph. But what happens? The height will be reduced. So there will be decreased height. So the volume will be much low. Time will remain the same. So the values will get, let's say VC will decrease 2.5 liter. FeV1 decrease, let's say 2 liter. So percentage will remain unchanged. That will be normal. So normal FeV1 percentage, that is 2 by 2.5 will give you, because both are decreased now, that is 80%. So that's why in RLD, what remain the same? In RLD, FeV1 percentage is not decreased, only the volumes will decrease. So what decreases? Decrease VC. decrease FeV1. But what is same? Normal FeV1 percentage. Now in obstruction, air flows slowly, so it will take more time. So that's why what happens, the volume will remain almost unchanged, but the time will increase. This is our OLD, increase time. So what happens here? Increase time due to slow flow rate. So obstruction cause a increase in the flow rate. Okay, so what happens? The flow rate will increase. So now see in the first second how much is coming. Let's say 2 liter. So what is the value now? So let's do. So there is a decrease FEN. So decrease FeV1 percentage. It is FeV1 by TVC into 100. सही है? So that is what value? That is around 40%. So that's why in OLD air is coming slow. That's why we see a decrease in FeV1 percentage. So what happens? The VC can be normal, but FeN percentage will decrease. So summary is very simple. Very simple. If they give a graph, look at the graph. If this is normal, what is this graph? This is RLD graph. If they give a graph which is very wide, so this is OLD graph. Very simple. So if the graph is wide, it is OLD. If small, so it is small graph. This is wide graph. So that is the diagnostic criteria for OLD and the RLD. Okay. So I hope it's clear. So I don't know what was the exact question. What I only received was there's a graph of this condition. So I don't know out of these what looks odd. Bronchiectasis is obstructive disease. These three are restricted lung disease. So I assume it will be the odd one, bronchiectasis, if it is the graph. Okay. So that will be the diagnostic criteria. Are you clear? So I hope it's clear. So I am going with option number A. So I don't know the exact answer, but I feel it should be it would be option number which one? Yes. Clear? Chalo. Let's start. Now comes the question. Okay. Neurohypophysis part of pituitary secrete what thing? So what is the neurohypophysis will do? So right, first is remember anterior pituitary release what? It release LH. I'll just do it properly. So first we know neurohypophysis posterior pituitary. Very easy question. Again, that's not in the notes, given the notes. Is posterior pituitary. So it is our posterior pituitary. Clear? So posterior pituitary is there. Done. Then it releases two hormones. One is ADH and oxytocin. So ADH and oxytocin. Fine. So ADH and oxytocin. And what the ADH do, I told you already, it comes from supraoptic nucleus actually. Supraoptic. And oxytocin come from what? It comes from our paraventricular nucleus. So question is, what will be the answer? It is ADH and oxytocin. Okay. Prolactin, GH, all they come from anterior pituitary. also called as adenohypophysis. Adenohypophysis. Okay, and melatonin is controlled by MSH. Sorry, melatonin is come from pineal gland, but MSH from intermediate gland. So it's from intermediate pituitary gland. Okay. Iron overload in the body is detected by. So again, I will just give an idea. It is given by almost all the methods. Heart iron level scan, yes, it is too invasive. You can do it non-invasively. Okay. Iron liver load, yes. For copper, iron, both are very important. Ferritin, yes. Ferritin saturation also important. Even transferrin saturation. They all are used. Okay. DMT is a iron transport. I don't know the exact option. I just got DMT. It is actually for iron transport in duodenum. So it's for iron transport. Is not the one. So I'll just show you the table. So ferritin more than 300 nanogram in male and 200 female indicate iron overload. Then transferrin saturation, when it exceeds 85, non-transferrin bound iron, that is NTBI, start to circulate, and that is now accumulating where? In the endocrine and the cardiac tissue, and that is done by labile plasma iron. Clear? So that is the case. So we can use what? Labile plasma iron, then non-transferrin bound iron, and also transferrin saturation. So this is the second method. So what that is? Transferrin saturation. Then also LIC. What is LIC? It is labile plasma iron plus also, yes, your liver iron content and cardiac iron overload. All are there. All are for this. Okay. So what are the summary? So ferritin and transferrin is, you know, the initial scan. But what is one of the most important? It is LIC and cardiac iron assessment. Okay. T2 scan you're doing MRI. So they are for, yes, efficiency of the chelator therapy you're giving for iron control, or they are indicating the, yes, high risk of iron overload. So that's why they are saying liver and heart are one of the best for iron overload. So if they are asking, answer is all above 3 are right. D is not for iron level. It is just a transporter. So best will be A, B and C. Okay, A, B and C. Clear? Best one. If they're asking best one, then it is your cardiac, which is showing the highest correlation. So it is saying this, I discuss. So best will be your cardiac marker. Okay, clear? So LIC, labile and cardiac, it is one of the best. Okay, clear? So they are the best for the assessment, cardiac one. Okay, because cardiac will always keep the excess. The liver can store even normal condition, but cardiac is indicating the highest possible levels. Okay, Raj? Choose the correct answer regarding location of macula densa. So now we all know macula densa is a part of what? It's a part of JG apparatus. JG apparatus. It's a part of JG apparatus. And it is for what? It sends GFR and correct GFR by tubuloglomerular feedback. Tubuloglomerular feedback. Okay. So it sends the GFR via what? Via tubuloglomerular feedback. So clear now? So now where are they present? So they are present in the DCT and ascending limb. So they are actually between DCT and ascending limb is the best, not CD and descending. No, this is not possible because descending and CD are separated by DCT. So not right. PCT ascending loop, ascending is again separate from, so they both are anatomically wrong. PCD and CD, no, it's basically ascending in this. Look at the diagram. So this is the diagram. You can see this is the glomerulus. Okay. See, PCT, I'll just show you now. See, PCT is connected to descending loop of Henle, not ascending. PCT connect to descending. You can see this now. So PCT connect to descending loop and then come ascending, then DCT. So anatomically also it is wrong. Priya, okay? Chalo. So look at this. This is a glomerulus. This is the afferent arteriole which contain the JD cells. What it contain? JD cells. So JD cells are in afferent. Then these are the juxtaglomerular cells. You can see JD cells. Okay. Then there are these mesangial cells which are around the glomerular capillary. Mesangial cell. Can you see that? These are mesangial cells. These are mesangial. And this is your urine which is coming from ascending loop and it is going to the distal tubule, that is DCT. So that's why the macula densa cells are present in the area between the ascending limb and the DCT. So answer would be A is the best answer. These are all wrong. So best answer is A. Okay. Next, arrange the sequence of events during the vomiting. So again, I have not got the sequencing here. So obviously what will happen first? So we have to inspire first. I'll show the order. See. So what happens? First saliva occur. Why saliva? Otherwise gastric vomiting can cause burn. So that's why first saliva occur, and this saliva is alkaline pH and it protect the airway. So there's sensation of nausea and there is alkaline saliva secretion which is there. Then there is inspiration, and this inspiration is causing the respiration to be stopped in inspiration. So what is the first step? Deep inspiration. Then glottis close to build the pressure. So glottis will close. Then lower esophageal sphincter will relax. So LES will relax. Number 3. Once the LES relax, so I'll just write 1, 2, 3. So once the LES will relax, what happens? There's a contraction of diaphragm and the abdominal muscle, which increase the intra-abdominal pressure. Okay. Now the duodenal contraction occur and also stomach contraction. This is called as reverse peristalsis. Why? They are going from stomach to esophagus, reverse direction. That is going towards esophagus. Toward esophagus. So that's why called as reverse peristalsis. And then as the pressure rises in the stomach, it causes the expulsion of the gastric and upper part of the GIT. That's why sometimes bile can come, because bile is again present where? In the duodenal area. So that's why it causes pushed out. So that is the case. So what are the order? Inspiration, glottis close, sphincter relax, then contraction of the diaphragm, and then duodenal and gastric contraction. Duodenal and gastric. So the answer. So what will be the sequence? So deep inspiration, number 1. Then there is closure of glottis. Clear? Then against, yes, there's relaxation of upper esophageal sphincter. So this relaxation and forced contraction against closed LES will be occurring. And then last would be your relaxation of the LES, and that will cause the thing. I think I just made a blunder here. Just 1 second. Okay. So first will be inspiration. So that is number 1. I'll write it here. Then there is closure of glottis, number 2. Then there is relaxation of the sphincter, LES. But here they say close. I don't know what is the concept here. So I don't know the exact option. It should be close or open LES. Chalo. Anyway, we'll go with this, number 3. And then there is contraction. So contraction will occur. Okay. So that it goes against. Okay. Fine. So we'll go with what order? 4, 3, 4, 1, 2. 3, 4, 1, 2. 3, 4, 1, 2 will be the order. Contraction will occur in stomach. It's forced gastric contractions. Okay. The vomiting reflex. Now, which of the following is true about the neurogenic shock? Again, I never got the options, but I'll explain what is neurogenic shock. In this case, what happens? There's a decreased sympathetic activity and could be due to either your spinal injury or shock, spinal injury, or some surgery, or drugs, or even spinal anesthesia. If best, I told you for best we will go for the cardiac iron estimation. Liver will be invasive one. Cardiac we can do even with MRI. Okay, so labile and this. Okay, clear? So that is the case. So it causes the spinal injury. Now that causes vasodilatation. So loss of sympathetic tone. So that causes vasodilation. Vasodilation. Okay, and this causes blood accumulation in the vessels. Blood accumulate. Blood accumulate in vessels, and as the blood accumulate in vessels, what is the end result? What is the end result? It causes warm shock. That's why it is called as warm shock, because the BP will decrease. BP will decrease, blood is not going to the heart. Also, it will inhibit the heart because sympathetic to heart will decrease, and also decrease heart rate, decrease stroke volume, decrease cardiac output due to decrease sympathetic to the heart. So there is a warm shock and there is also a decrease in the heart rate, etc. Okay. So peripheral vasoconstriction, no, there is a vasodilation, that is the rule here. Anaerobic produce CO2, yes, it's true, but it's not related to neurogenic shock, no. So I don't think it's what kind of option. Active lysyl enzyme due to low pH, yes, low pH can trigger enzyme, but it can not be one of the reason in neurogenic shock. So the warm shock looks the best answer, and treatment will give vasoconstrictors like noradrenaline, which cause vasoconstriction and also stimulate beta 1. So that's why it is beta 1. So alpha 1 vasoconstriction and beta 1 will cause cardiac stimulatory actions. Okay. So yes, this is the bradycardia with hypotension or warm shock. I don't know. So I'll go with D option, which is looking the best or right. Okay. So these were the question I got. If any change you can inform, I will get them corrected and I will incorporate so that we can use it later in this case. Clear? So clear now? So I'll wrap up the session because the next class will start at 8 o'clock. Okay, so next session will be starting. So I'm just saving this PDF so that anyone who want, I will send them to you. Okay, for any doubt, queries, you can just send me on Telegram. 9899 529468 is my number. On Telegram, I'll be replying to the queries. So just telegram me, okay? And best of luck for your NEET, because that is very, very essential, because maybe from next year there would be next exam. So we have to give our best to get very good rank in the NEET exam on March. So best of luck for NEET. So I'll wrap up the session. I cannot see any replies, so I just thank you very much.